This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, today our topic is angina without obstructive coronary artery disease. And with us, we have a special guest, Dr. Janet Wei, who's an assistant professor at the UCLA, a cardiologist at Cedars-Sinai. She's also associate director of the fellowship program. She's involved in the stress echo lab. And she works with a very long-time friend of ours, Dr. Noel Berry-Mertz, at the Barbara Streisand Women's Heart Center. So, Janet, welcome to MyHeart.net, and thank you very much for accepting this invitation.
Absolutely. Thank you so much for inviting me today.
Well, today we're going to talk about angina, and angina is basically a chest pain or chest discomfort caused when the heart muscle doesn't get enough oxygen-rich blood, which causes ischemia. It may feel like a pressure or a squeezing in the chest, may radiate to the shoulders, the arm, the neck, the jaw, or the back, and it may even feel like indigestion. The way we work up angina is we perform usually a coronary angiogram. It is the reference test for identifying obstructive coronary artery disease. In Europe and in the United States, approximately 4 million elective coronary arteriograms are performed each year, of which up to 50% show no obstructive coronary artery disease, yet have demonstrable ischemia. It's a condition that is associated with impaired quality of life and even increased morbidity in certain groups. So today we'd like to increase the awareness of this problem, characterize this large undifferentiated subgroup of patients, and discuss the different treatment options according to a special test, a functional coronary angiogram, and we'll talk about that with Dr. Wei. So, Janet, please, let's start a little bit by trying to recognize who are these patients, who has, angina and with ischemia with no obstructive coronary disease.
Yes. So this condition actually occurs in both men and women, although we have seen that at least 50% of women who have no obstructive coronary artery disease going to the cath lab have this abnormality of coronary, either microvascular dysfunction or coronary vasomotor dysfunction, where there may be actually vasospasm going on, contributing to their angina and ischemia. Whether we diagnose this dysfunction invasively or non-invasively, that's where we get some differences in numbers, but it is quite prevalent. And we have initially described a particular cohort of women with angina, often very persistent, can contribute to a significant amount of healthcare burden, whether it's recurrent non-invasive testing, recurrent invasive testing, multiple ER visits, or actual hospital admissions. And these are patients who may have been told that their chest discomfort is in their head, because once they go to the cath lab and the angiogram shows no obstructive disease, unfortunately, many of these patients have been dismissed as having cardiac etiologies of chest discomfort over the years.
Well, thank you. Of course, we have also the group of patients that have other heart disease, like, they can have hypertrophic cardiomyopathy or even, dilated cardiomyopathy, even some have myocardial bridge, but we're not going to talk so much about those today. Is that right?
Yes, we can focus on the primary coronary microvascular dysfunction and coronary vasomotor dysfunction. You're absolutely right. There are secondary causes of coronary vasomotor dysfunction in patients with pre-existing myopathies, pre-existing valvular heart disease. But I think the awareness needs to be in the general population who do not have these pre-existing cardiac conditions, who may then present to your office with chest discomfort found to have no obstructive disease by invasive angiogram or CCTA, the coronary CT angiogram.
So, Janet, are there any particular risk factors to have this kind of problem, or is it the same risk factors that we find in patients with obstructive coronary disease?
Yes, that's an excellent question. We have found that the traditional coronary risk factors do explain to up to about 20% of the coronary of this condition, coronary microvascular dysfunction. But 20% is not a lot. So there's still a lot we don't understand. And we have found that, while the majority of these patients actually do not have pre-existing traditional cardiovascular risk factors like hypertension, diabetes, hyperlipidemia, we do feel that they likely have some sort of pre-existing condition that's then leading them to have precursors of atherosclerosis. And indeed, in the women's ischemia syndrome evaluation, which was started over 20 years ago by Dr. Barry Merce to study ischemia in women, they've actually found that up to 90% of the women who presented the cath lab and found to have apparently normal-looking coronary angiograms actually had atherosclerosis by intravascular ultrasound. So we do feel that underlying atherosclerosis is a significant trait consistent in all of these populations.
So basically we have the classic ones like the smoking, the hypertension, the diabetes, obesity, and stress. I mean, all of that basically, comes into play when you have angina or ischemia with no obstructive coronary diseases.
Yes, it certainly can come to play. Those are all traditional risk factors that can lead to obstructive coronary disease, non-obstructive coronary disease, and endothelial dysfunction. Endothelial dysfunction is part of this problem where the lining of these coronary arteries just aren't able to dilate appropriately to whether it's physical stress or emotional stress. And in fact, in some situations, these vessels with significant endothelial dysfunction will constrict, will vasospasm.
Well, you're kind of going into that next chapter, which is, how can you have chest pain, angina, ischemia, and not have coronary disease? How's that possible?
Yes, that's the question of anatomy versus physiology. And so to think about how we can have ischemia in the setting of non-obstructive epicardial disease, we have to remember that although we can see the epicardial vessels on the angiogram, there is a huge network of the microcoronary circulation. And when we think about the artery as it gets smaller and smaller and smaller, we have to remember that these smaller vessels, which are generally less than 400 micrometers, we call them prearterioles, and as they get smaller, they're arterioles. These vessels are actually responsible for over 90% of the coronary resistance in the myocardium. And so they have a huge role in both the metabolic control and other regulation of flow in the settings of stress or even at rest. So although we can't see them, they're working very hard to keep this balance of blood flow to our myocardium. And therefore, if there is dysfunction of these smaller vessels, these prearterioles and arterioles, such that they either have an impaired vasodilatation response or an increased vasoconstrictive response, then we will see ischemia, and then the patient will experience chest discomfort or other angina equivalents.
There's this great picture of the coronary arteries, showing basically what you're saying. The 5% of the coronary arterial tree is the one that we image on coronary arteriogram. And then when you kind of show, like this is just the tip of the iceberg, the whole coronary vascular tree is so complex, and the patients are shocked when they see that. As a matter of fact, we should kind of incorporated in our title of our topic today, just mind-boggling, what we're talking about. So Janet, let me ask you, what is the typical workup? I mean, obviously you have these patients, that have had some chest pain. Let's say a patient goes to see you in the office. I mean, first of all, you want to look for the ischemia. How do you do that in the office? And what's your next step?
Yes. So it kind of depends if they already had a prior evaluation of obstructive disease or not. And so if they've already had evidence of, a angiogram or a CT angiogram showing no obstructive disease, or even a non-invasive test where they had low likelihood of, a perfusion defect or stress echo abnormality for obstructive disease, then we will often think about this coronary microvascular dysfunction or coronary vasospasm. And because of the imperfectness, I would say, of these diagnostic modalities, it also depends on where the patient is. So in my center, we have the availability of more advanced imaging to specifically diagnose coronary microvascular dysfunction. And we have the invasive testing, as you mentioned, the functional coronary angiogram. But if you're not at a center that is able to do, for example, stress cardiac MRI to evaluate myocardial perfusion reserve index, which is similar to coronary flow reserve, or even a stress PET scan that also allows you to calculate coronary flow reserve, then you may consider empiric treatment. So for patients who already have some cardiovascular risk factors, the traditional high blood pressure, hypercholesterolemia, we will often treat them empirically to lower their LDL, to get their blood pressure under goal, and use the traditional anti-anginals. But if we really want to get a diagnosis, if the patient has already had, refractory angina, may have limited options, or who may have a higher risk, such as they already had a myocardial infarction in the setting of no obstructive disease, also what we call MINOCA, then that's when more definitive testing is merited. And so we will often do the non-invasive testing first, just to allow us to have a diagnosis, then pursue treatment. But again, if they really have refractory symptoms, a higher need for a diagnosis, then we will go to the invasive testing route.
So we have this patient that has demonstrated myocardial ischemia on the thallium, a small defect. They're having a lot of chest pain, not a very good quality of life. You bring them to the cath lab, your cath lab, and you do the coronary arteriogram. You don't find any, obstructive coronary disease, which I guess here we can define, lesions that are less than 50%, blocked. What do you do next?
Yes. So usually when we have a low suspicion for obstructive coronary disease, we will have our cath lab prepared to pursue the invasive coronary function testing. But in most cases, the cath lab is not prepared to do subsequent invasive testing. And thus, if you do not have the capability to do more functional testing, then usually that's when the angiogram stops, right? The patient is taken off the table, and we would recommend the traditional anti-anginal therapy, not to give up on treatment just because you didn't see an obstructive lesion. These are the cases where we would try beta blockers, calcium channel blockers, add on ACE inhibitors or angiotensin receptor blockers, as we have found that these agents do improve coronary flow reserve, to add on statin therapy when you see some non-obstructive coronary artery disease. And then in some patients, they are responsive to nitrates, although we typically find that it's a mixed bag. Nitrates may not be effective in those patients who have primary small vessel dysfunction because of the absence of those receptors dilating. But if there's any component of larger vessel constriction, they may be responsive to nitrates. Other alternatives are ranolazine in the setting of patients who just have refractory chest discomfort. And for all of these patients, though, we talk about lifestyle changes. So if there are cardiac risk factors, poorly controlled diabetes, poorly controlled blood pressure, weight, we will counsel them to make those lifestyle changes, and almost always refer them to cardiac rehab because we do find that to be helpful to improve their symptoms and quality of life. In the situations where we are prepped in the cath lab to undergo further invasive testing, there's different protocols existing throughout the world. Probably every investigator has a different, slightly different protocol. I can describe to you the protocol that we use in the Women's Ischemia Syndrome Evaluation, the WISE study. And in these studies, we use a Doppler wire that's placed generally in the left anterior descending artery so that we can measure coronary flow reserve to intracoronary adenosine. Normally, adenosine should be able to dilate our coronary vessels, but increase coronary flow at least 3 times compared to baseline in the healthy population. There's different cutoffs that people have used for abnormal coronary flow reserve. We tend to use less than 2.5 to be abnormal and diagnostic of coronary microvascular dysfunction. And that generally is what we would diagnose as non-endothelial dependent microvascular function. But the endothelium, as I mentioned earlier, plays also an important role in the function of these vessels. And one way for us to interrogate endothelial function is to use intracoronary acetylcholine. Acetylcholine, when given to a healthy artery, will allow, through the cyclic GMP pathway, allow increased nitric oxide to dilate the smooth muscles of the arteries. And thus, we would see increased blood flow as well as a dilated coronary artery. However, in the setting of endothelial dysfunction, there's impaired increase in vasodilation or even vasoconstriction. And so we have ways using the Doppler wire calculation of coronary blood flow to calculate if they just aren't able to increase their blood flow over 50%, that's abnormal. If they have a constrictive phenomenon to acetylcholine, that's abnormal, and they have endothelial dysfunction. Lastly, we do give nitroglycerin at the end, just to make sure that they have a normal epicardial kind of smooth muscle response to nitroglycerin that can sometimes help us tease out whether the patients have mostly a smooth muscle abnormality or if it's just part of the endothelial dysfunction response.
Just wanted to bring our patients, in par with what you're talking about. The endothelium is the most inner portion of the coronary artery, and the media is composed mostly of the smooth muscle. So these arteries are not like rigid pipes. They really kind of react. They have muscle in them, and with these, these medication like adenosine and acetylcholine, you can see whether someone has a tendency to have coronary spasm or has a abnormal vascular tone or normal one. So these are, pretty important part of your functional. There was another study done in England, the Carmichael study, pretty much kind of the same protocol, Janet, or?
Yes, very, very similar. And this Carmichael study was truly a landmark study because it was a clinical trial that randomized patients to get the invasive coronary functional testing to help determine whether a stratified medicine protocol, would actually make a difference in outcomes of angina quality of life. So what they did was they were able to determine, if I diagnose someone as having coronary microvascular angina versus vasospastic angina, versus what I feel to be non-coronary related angina because they had normal coronary function testing, would that actually make a difference in their angina? And they indeed found that this type of stratified medical therapy improved angina based off of the Seattle Angina Questionnaire and quality of life, even up to 1 year in their follow-up. And what this tells us is that, knowing the diagnosis can really change outcomes. And unfortunately, we're just not making the diagnosis in the large population of these patients who have angina, but no obstructive coronary arteries.
That's half the treatment. I think if you know what's wrong, and instead of being told it's all in your head, maybe you can kind of, if you understand, then I think you can probably realize what's going on and do everything you can to help yourself. So it seems like they've stratified a little bit, their treatment that way, didn't they?
Yes. So the stratification was related to whether they diagnosed coronary microvascular dysfunction versus vasospasm. For the group that had vasospastic angina, their first-line treatment was a calcium channel blocker in a combination with long-acting nitrates. They also have a medication, nicorandil, which is available in Europe, which unfortunately we don't have, which allows them to have extra vasodilation as it acts on the calcium channel ATPase type mechanism for vasodilation. Here, at Cedars and also other institutions throughout the U.S., we probably focus mostly on calcium channel blockers and the long-acting nitrates. We have more limited options here in the States. Their recommendations for microvascular angina was to actually start patients on ACE inhibitors or angiotensin receptor blockers. This is based off of data from the Quinapril study from the WISE group. The Women's Ischemia Syndrome evaluation found that Quinapril, which is an ACE inhibitor, did improve coronary flow reserve as well as the angina. They also recommended initiating a statin to consider exercise, other regimens including L-arginine, ranolazine, Fasudil, which we again don't have here in the United States. And then also considering other non-medication related therapies such as extracorporeal external counterpulsation, EECP, which can be helpful in some patients with angina due to microvascular dysfunction.
How many patients did they have in CORMICA?
They enrolled 391. 151 were randomized, so 75 in each group. And so 75 of those patients were diagnosed with either vasospastic angina or microvascular angina. And then they also had a group that, of course, they felt to be non-cardiac. 52% of their patients were diagnosed with microvascular angina. 17% of their patients were diagnosed with vasospasm. 20% had a mixture of both vasospasm and microvascular angina. And 11% were felt to be non-cardiac due to some sort of heightened pain response. And in fact, heightened pain response is something that we may see in our population. We tend to ask them during the cath, are they feeling chest discomfort just during initial angiography with contrast? But of course, a good number of them also have microvascular dysfunction or spasm. So it's not something that we can exclude, truly ischemic causes of their chest pain.
Yeah, it seems like some of our patients have a heightened sense of the chest pain or the chest discomfort. You just inject the coronary arteriogram, they contrast, inside the coronary arteries, and they feel it. Yet
That's right.
There's no obstructive coronary disease, and there may or may not be microvascular disease at all. It's just an increased sense of the pain.
That's right. And that can be very reassuring to the patient. Those are the patients that we will say, you know what, in light of your angiographic findings, next time let's try a low dose tricyclic antidepressant focused for pain reception improvement. These are patients we would tell, not to continue to go to the ER and be hospitalized for potential unnecessary, potentially harmful, testing. And so both the diagnosis as well as, the absence of significant microvascular dysfunction or spasm can be helpful to patients.
Sounds great. So basically, they almost kind of simplified the protocol. I mean, they had these patients, they randomized them to either, conservative regular treatment versus, dysfunctional coronary angiogram, and basically tested for microvascular disease. They tested for coronary artery spasm. And then there was really completely a cardiac chest pain at all. That was maybe 10% of the patient. But really the vasospastic angina was that they really, described they were giving acetylcholine, pretty high dose, triggering this coronary spasm where the artery closed off almost to 90%, so very, very significant coronary spasm with chest pain and ST changes on the EKG, something that was relieved, of course, with nitroglycerin. But then the majority were this microvascular angina with a combination of, vasospasm, but not quite to the extent where it closed down the artery completely. It seems like this, there is a component of vasospasm, or I guess we used to call Prince metal angina. For years we've been describing that, very, very common in Japan, in Asia. But I think it helped kind of stratify, patients, identify maybe their pain, really help with the improvement of their quality of life and prognosis of these patients, and help with the medication. It's kind of helps also to have a little guidance So how do we treat these patients? Who's going to respond, to what? And I was a bit surprised to see that Ranexa didn't play that much of a factor in this group population.
We also did a study with the Women's Ischemia Syndrome evaluation for ranolazine to determine whether ranolazine would improve angina, or even a non-invasive measure of flow reserve through MRI. And this was a randomized controlled crossover trial. We called it RWISE, and found that it was a negative study, that it did not improve angina by the SAQ questionnaire or MPRI. However, in a subgroup analysis that was pre-specified in those who had prior low coronary flow reserve, less than 2.5, that subgroup did seem to improve to ranolazine. So the Formica group did include ranolazine as part of their treatment algorithm for the microvascular angina subgroup, but we do need a lot more trials for determining what is the best strategy within these different subgroups.
Well, let's talk about prognosis a little bit, because you have this incredible wealth of data, from the study in women, the WISE study with 10-year, follow-up. So tell us a little bit about, who composed the WISE, patient population, who were these women, and how did they do, long-term, up to 10 years?
Sure. So WISE, just to review, WISE studied actually almost 1,000 women total, 936 symptomatic women who underwent clinically indicated angiograms. But 2/3 of them, 540 of them, actually had no obstructive coronary disease. And so the early studies were focusing on the fact that even the patients with no obstructive coronary disease had actually a 13% 10-year all-cause mortality. Now, that is less than the group that had obstructive coronary artery disease. They had a 36% 10-year all-cause mortality. But interestingly, 1/3 of all the cardiovascular deaths actually occurred among women with no obstructive coronary artery disease. And subsequently, Dr. Carl Pepin, who's the WISE investigator at University of Florida, he looked specifically at coronary flow reserve in the patients who underwent this coronary function testing, and found that coronary flow reserve did help predict who had worse outcomes compared to those who didn't. And it seemed that a threshold of about 2.36 was the best threshold for predicting which women with no obstructive disease would have worse outcomes. We've also subsequently showed that the acetylcholine response also predicts outcomes. And this is not unique to the women study. This has been found in multiple other cohorts from the Mayo Clinic. Dr. Amir Lerman has led this, showing that endothelial dysfunction predicts adverse outcomes, and not just related to the heart, but also in stroke. Coronary endothelial dysfunction increased ischemic stroke by 4 times compared to those without coronary endothelial dysfunction. Dr. Kayumi from Emory has also demonstrated this in patients with completely normal appearing coronary arteries versus and those with some mild atherosclerosis, finding that these coronary flow reserve or coronary endothelial dysfunction responses do predict worse outcomes. Now, interestingly, the WISE study found that that heart failure hospitalization was actually a cardiovascular outcome that was 2 times more frequent than actual myocardial infarctions. And this has led to a lot of interesting research that we're doing and others across the globe to investigate the relationship between coronary microvascular dysfunction and a condition called heart failure with preserved ejection fraction. We think that these are 2 conditions that occur quite frequently in women. And the unfortunate thing is we don't have a good treatment for HFpEF. And so whether coronary microvascular dysfunction might be a precursor is something that we're very interested about, to see how we can understand mechanisms for the purpose of future treatment and prevention of HFpEF.
Very interesting. How does it compare? You mentioned a lot of cohorts there in Atlanta, but there is also a study in Stanford, and I don't know whether their patients are healthier or it's a different patient population or selection. It seems like they have a lot less mortality. Maybe they have less coronary disease or less atherosclerosis, I should say. Or how do we explain that?
Yes, Dr. Tremmel and her team have studied both men and women using coronary function testing, and she has said that her patients do very well, and she's probably giving they're being treated with preventive therapy with statin, with ACE or ARB. So I don't know the details. I don't think I've seen the publication showing really a description of her cohort. But that's kind of where we need longer follow-up. We found that the heart failure hospitalizations had a signal even within 7 years of follow-up, and whereas MI was very low. And so I think certainly there may be just differences in the two groups. We also want to keep in mind that there are certain conditions in women where if they did have a MI with no obstructive coronary artery disease, we should consider evaluating for a hypercoagulable state. You mentioned early on, potential risk factors for these conditions. And we have been diagnosing some of these women with factor V Leiden mutation, prothrombin 2210. And so it's just something that, not to be neglected if they are having recurrent MIs in setting of no obstructive disease.
Very good point. So I think we're getting a clear picture of how we treat these patients. Patient with the vasospastic component, we go, of course, smoking cessation, but calcium antagonists and long-acting nitrates. And patients with microvascular angina, we go more toward beta blockers, ACE inhibitors, statin, of course, lifestyle changes. And but obviously it's very difficult. I think your point is well taken in the Y study. You have such a long-term follow-up, still showing any worse prognosis in these patients. Some leading to HFpEF where we have so little treatment. Although I'm still crossing my fingers for SGLT2 inhibitors roll in there like they have in everything else.
Right.
So what do we have? What is the research looking like? I know you had mentioned in the past, well, first of all, I think we have the Warrior trial still going, right?
That's right.
Which is studying statin, ACE inhibitor, and aspirin in women, sponsored, I think, by the Army. But we have also other interesting research that you're doing at your site using stem cell. Can you tell us a little bit more about that and what role would the stem cells have in this condition?
Yes, we and the Mayo Clinic did a small study. It was a phase 2 open label trial for men and women with coronary microvascular dysfunction. They had to have a coronary flow reserve of equal or less than 2.5. This was a small study of 20 patients. And the goal was to evaluate safety and potential bioactivity, where a single administration of GCSF mobilized autologous stem cells. So each of these patients actually went through 5 days of GCSF, and then their white blood cells were collected at the end of the day, and then sent, and then ultimately delivered down their left anterior descending artery. 6 months later, we re-evaluated their coronary flow reserve. They also had exercise treadmill testing, angina questionnaires, and their 6-month coronary flow reserve did improve from a baseline average of 2.08 to 2.68 at day 180. And their Seattle Angina questionnaires also significantly improved in all of the 5 domains. And so this was kind of a proof of concept study. There was no evidence of any cell-related adverse events. And now we are starting a phase 2 clinical trial that is randomized, placebo-controlled, in a larger capacity, so multi-site study, and recruiting again both men and women with invasively determined coronary microvascular dysfunction CFR less than 2.5.
What's the mechanism, do you think?
That's an excellent question. You know, a lot of the stem cell studies, at least in the heart failure categories, have found that it's not that the stem cells are there fixing the endothelium or the microvasculature, but there may be more hormonal related, other kind of ancillary, stimulation that we just can't measure directly from the stem cells activity. So we're interested to seeing how this pans out. These types of stem cells have been shown to improve claudication in peripheral artery disease, potentially with similar mechanisms. And so we're going to see if it does the same in the coronary vasculature.
Well, I can see that with Dr. Eduardo Marban, working in your group over there at the Barbara Streisand's Heart Center, I can see a lot of, stem cell protocol, originating and being conducted at your site. Anything else, Janet, in that field that is kind of going on, looking into the future, or maybe started particularly after we're through with COVID pandemic, I hope one day?
Yes, we are actually interested in more point of care testing. As you mentioned, Dr. Bouchard, what do we do when a patient shows up in the cath lab and has normal coronary arteries, or at least non-obstructive coronary arteries? The testing often kind of halts there. And so we have developed more of a point of care type of coronary function testing protocol led by one of our interventionalists, Dr. Bruce Samuels, with the hope that more interventional cardiologists will be able to easily reach for this testing to be done in a more quick, expedient manner, and then provide this type of diagnosis to the patient. So we're just having them do 1 dose of adenosine, 2 doses of acetylcholine, and then nitroglycerin following, to make it kind of a very quick step. There's not as much of the research related, detailed methods that we do, but I think will be sufficient, similar to the Formica trial, really geared towards providing the stratified medical treatment for patients.
And for the patients, it's like having an arteriogram that, you don't feel any difference. It can be done through the wrist. You have a catheter, you do your coronary angiogram, which takes about 5 to 10 minutes. And then after that, all you need to do is introduce, a special wire, Doppler wire or thermodilution, so you can measure coronary blood flow. And then you give your medication. But, I guess if you go through the whole protocol, it adds maybe a 60-minute, to the coronary arteriogram. And that's why it kind of makes sense to really shorten it and really try to get specific answers for the patient, and hopefully have a full adoption, with the different cath lab around the United States.
We have found, and we have published safety of this type of testing. The WISE group has, the Mayo Clinic group has, the Germans and the UK groups have all shown a very low, less than 1% adverse event, and complications, are by far less than the actual risk of major adverse cardiovascular events due to the actual disease. So, and our centers, in the setting of capable, experienced hands, we do strongly recommend this type of diagnostic testing to be done, just to be able to provide some answers and guide treatment.
So important. So, because we can't ask all of our patients that have no obstructive coronary disease and chest pain to fly to LA to see Dr. Janet Way, but we need to be able to do this at home as well. And I think the implementation of a simplified protocol will help a lot and really encourage, interventionalists as well as, the cardiologists to implement this type of treatment instead of saying it's all in your head, and really turn the patient off, completely, to really have something where we can explain their chest pain and maybe have a way to treat them. Dr. Janet Way, thank you very much for your great teaching about the functional coronary angiogram, something that we're not used to here, but it's such a common problem that now to have a way to define this problem and a way to treat it and will make our patients much more appreciative. Thank you very much, Janet.
Thank you, Dr. Bouchard, for highlighting this important problem today.
Appreciate it. Thanks.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.